Great, thanks, Nishant. So we'll get my slides started. So this is background. So I think there's a lot of parallels in that we're also talking about an OBOT model, so not dispensing buprenorphine on site. I am a primary care provider and also do addiction medicine. And I'm going to talk about similar things we're doing in two different models where we are forgoing toxicology at this time, both in the primary care practice at comprehensive care practice at Bayview, and then the mobile van, the P-Care van that's for reentry outside the jail. So as a background of a practice pre-COVID, comprehensive care, all providers prescribe buprenorphine. We have over 600 patients in long-term treatment for BUP. They all come for their primary care as well, includes HIV, Hep C, co-located. And usually it's 15-minute visits, and patients are seen between weekly and every 3 months, depending on their stability. We encourage therapy in groups, but don't have any on site, and they're not required. Have a practice of starting buprenorphine at the first visit, and then would often do nurse or lab visits for increased toxicology monitoring for less stable patients with provider visits to help with the schedule. The other site is the Project Connections to Reentry, which is part of under BHLI and mobile treatment side. This is the van here, formerly from Reach. I think the old posters didn't cover as much. So patients can come. It's parked outside the Baltimore City Detention Center on Eager Street, so people can do walk-on treatment. It operates now 5 days a week. We use oral toxicology at that site, so that provided more challenges during COVID. And then always have a phone number staffed by nurses available. Mostly it's a really underserved population, high rates of homelessness. Many don't have phones. And so when you talk about telemedicine, there's some unique challenges. So similar, I think, to all of you, it was rapidly needing to restructure how we offered care. So for the van, in the mid-March period where community rates were rising, but we wanted to maintain access to care, we set up this camping style pavilion. And then that's the entrance to the van. There is no way to keep really any physical distancing on the van, which has 2 small rooms and a little hallway where often patients were waiting on the bench. And logistics of doing even urine was hard. While there is a bathroom, it's often not working. So we do oral point of care swaps. So, and then there was really an issue because it's of even having PPE. So what we did in the beginning to transition to make sure patients were aware that we would be transitioning to telemedicine was for 2 weeks in March, patients would come, we would encourage and try to space these chairs 6 feet apart while they were waiting, and the patient would come to the front of the steps while a nurse kind of sitting there and the physician would talk to them. And we have community outreach and peer staff, and we'll talk about, we're continuing to use those for supports, but we early on had them go to do that by phone and not be on site. And then we transitioned, and then we were letting patients know during this, should say for the van, because it's a less stable population, it's mostly weekly prescriptions and visits. And we started to space out to every 2 weeks and let patients know that things might be changing to prepare them, including signage. And then by early April, we had switched to all telemedicine for the P-Care van. It's by Zoom. And I should say that really it's mostly phone. The video is nice because it's simultaneous with the nurse and the provider, either a mid-level provider or a physician who's waivered. But most patients lack internet. They're often sharing phones, calling us from the pharmacy phone, so really are not actually using the video platform. We are still doing new initiations. And comprehensive care practice, CCP, is part of the Hopkins system. So it's mostly video through the Polycom platform for Epic. There's been a lot of issues with logistics. So, and that video working and patients getting used to it. So based on the provider using backup methods. So neither of these sites, previously CCP has a lab, and we would do urine toxicology on site and oral swabs as mentioned for the van. And we're not doing on-site toxicology based on the concern for risk and wanting to maintain access for our patients and not having that space to be able to do it the way they're able to do it in MAC clinics. And then other measures, we really, especially for all of these populations, again, has been mentioned by other providers, really balancing risks and benefits and not even knowing the full risks that you have to balance. And so wanted to really maintain access and flexible patient-centered treatment. And since buprenorphine is a safe medication, feeling okay with longer supplies. So we spaced to monthly visits for P-Care. So with that 28-day supply, and we're checking closely with our pharmacy partners, we have a direct bill program to help pay for uninsured patients' medications or their copays if they can't pay for the copay for the van. And so we're off checking very closely with pharmacy partners about supply issues, and which pharmacies have it in stock on that day. And so it's depending on the patient's stability and really their ability to keep medications safe. We'll either provide that as a 4-week prescription all at once, 2 weeks with 1 refill, or 1 week supply with 2 refills. Particularly, I'm always asking my patients about if they have a lockbox, if they're staying in shelter and moving around, I'm more likely to give them shorter supply with more refills, but also balancing that with whether they can get to the pharmacy. And while we also cap at 24 milligrams daily, usually start people at 16 milligrams, and for really have, because of the concern for diversion at higher doses and knowing that 16 milligrams is effective for most people, have capped the dosing starts at 16 milligrams. Usually is, and this is the sublingual buprenorphine naloxone films twice daily. And then are using our peers, our outreach team at a clinic. We have case management and community health workers and lots of active outreach on behalf of patients to that point of trying to do supports, letting them know if they have the technology about things like in the room and other mutual support groups that can be used. And then we also keep the van with the driver still parked outside the detention center with a sign for the phone number to remind people, and also naloxone for distribution. So also we had an issue, even what will happen is there's been times when the van wasn't working or parked slightly different, that patients will tell us they come and they look from the end of the block, say Eager and Fallsway, and if they don't see it, they'll keep going. And so even just leaving a sign wasn't enough. So we'd have that to just help them know what the resources are, and then try to be really flexible. They have a general day that they're supposed to check in, and we'll do outreach, but available all the time, and then they can always leave messages on our phone line. So I think some of the successes, so it was a challenge, and thanks to our nursing staff and our lead nurse, Lizzie Spradley, who's on this call, managing a lot. We had over 60 new intakes during the end of March, because a lot of programs closed to new intakes during that period. And then I've been pleasantly surprised that most patients have been able to find a phone, even if it's borrowed or even if it's calling from the pharmacy, because we're really worried about equity issues and access for there. At CCP, I've actually found there's patients I'm able to connect with by telemedicine because there's not a transportation barrier. A lot of patients are coming from Dundalk and Southeast Baltimore County, where the bus and public transportation lines are harder. And then what we've tried to do to balance is, even for my staple patients where I may have only seen them every few months, increasing that to monthly visits, because we can do more check-ins, and trying to provide that support since we aren't doing monitoring through toxicology and other ways. And I found really high follow-up rates and able to maintain access to care. And we're able to do the majority of our visits as full video telemedicine visits through CCP. I think the challenge, and we're accepting the risk of a longer prescription without toxicology, particularly the concern about diversion. But it just maintained that we want to maintain access for people. And then particularly because of a lot of other traditional OBOT sites in FQHCs and other primary care settings, it's taken time to figure out how they do that and how they do new intakes. And so since the van was more flexible, serving as a safety net, and while we normally expect some continuity, accepting the fact that we're maybe going to have people come once for a 1-month prescription while they get into care other places, and we still try to transition them to other care. We still worry about inequity in access for patients without phone or internet, and you're not able to provide the same always quality of services and supports when it's not a great phone line, sometimes in a public place. On the CCP Hopkins side, there have been a lot of technical difficulties with transition to the Polycom platform and need to adapt to alternate platforms and how you communicate with staff. But overall, I'd say that we're as a provider, I feel like I'm able to connect with and provide support to patients, and we will be thinking in coming days, we're already starting to do the planning of what a phased approach would be, bringing higher risk patients back. We now have more PPE for our staff. We'll continue to have the peers do most of their peers and outreach team supports by phone and by telemedicine, since they've been able to connect that way, and keeping it to a minimum of the staff that's present. So with that, that's the end of my slides. I think I'll give it over to Nishant for questions.